Ken and Nicole, thank you very much for the opportunity to present today. So ethics in professionalism, keys to success or necessary evils. I have no disclosures with regards to this. I try to think of myself as ethical and professional, but sometimes people who, like, when there's a complications talk, the person who has the most complications gives the talk. I'm not sure where I stand on this one, but maybe we'll figure that out by the end. So as physicians, when we start off, when we finish medical school, we all undergo the Hippocratic Oath. We all cite this, maybe not exact words, it's some form of this, some kind of pledge. It's pretty much based upon this. And thinking about this talk today, it made me look back at the Hippocratic Oath, not the one on the papyrus over here, but a more modern one. And some of these things are changed or antiquated, but when you look over this, it really makes you affirm of why we want to be physicians and the honor and the privilege that's bestowed upon us to take care of these patients. I will apply for the benefit of the sick all measures which are required, avoiding these twin traps of overtreatment and therapeutic nihilism. If you go through this list, it really does affirm that we do want to do the good things. We do want to do the right things. But sometimes other things in life, other situations, the herd is moving this way. We're told to move this way. And at some point, we have to take a step back and say, what is the right thing? And always do the right thing. And that can be hard. There are 4 basic principles of medical ethics: respect for autonomy, beneficence, non-maleficence, and justice. I put the Latin in here for those Latin scholars that are here. I unfortunately took 6 years of Latin, so I recognize some of these words. But you'll see some of these words in here too. Respect for autonomy. The patient has the right to refuse or choose their treatment. That makes sense. Beneficence. A practitioner should act in the best interest of the patient. Non-maleficence. Primo non nocere. There's the Latin. First, do no harm. And that's the one that's most widely quoted. But that's not enough. And justice concerns the distribution of scarce health resources. But if you build upon these other things are where people kind of trip up mostly these days. Respect for persons. The patient and the person treating the patient have the right to be treated with dignity. And we'll talk more about this, but I think when we think about some of the ethical or professional issues, these are the things that rise to the occasion. So what is my qualifications to give this talk? Well, I run the quality and safety program in our Department of Surgery. And so I unfortunately see a lot of the instances where these things don't happen. And that flavors a bit of how I'll be presenting this. I'm not an ethicist, I'm not on the ethics committee, but from a quality and safety standpoint, we see where it breaks down. They have the right to be treated with dignity. That's a big one. Truthfulness and honesty. Here it speaks about informed consent, but it's truthful and honesty in all dealings. When we join a professional body, whether it's the American College of Surgeons, SAGES, or other professional organizations, a big hallmark about that is the ethical standards. In fact, if you look at becoming a fellow of any of these things, and I put up here the American College of Surgeons pledge, it wraps in all these biomedical ethics concepts really into one sentence. I pledge to pursue the practice of surgery with honesty and to place the welfare and the rights of my patient above all else. I promise to deal with each patient that I would wish to be dealt with as if it was the patient's position, and I will respect the patient's autonomy and individuality. And it's based upon a code of ethics. It's listed here. We're obviously not going to go through all of this information here. But these aspects are critical. And for anybody who's been deposed or on the stand for one reason or another in the court of law, one of the first things that they always ask is this: Doctor, are you with the American College of Surgeons? Do you take a pledge with regards to that? And did you say this? And then they go from there. That's not why we should do these things. We should do these things anyway, but you should think about that as we move on. SAGES has been integral with regards to that. And this is an upcoming book that will be published this spring, the SAGES Manual of Ethics of Surgical Innovation. So when we start talking about patients, clinical trials, the introduction of novel techniques and technologies, when we think about research just beyond clinical care as well, then there's special aspects of ethics that we really need to take into consideration. How do we learn this? Well, this is how The Surgical Council thinks we should do this. So the SCORE curriculum. You have 42 different things here. I'm not going to go through all the 42 different things. That would take a little bit of time. In 42 things with regards to professionalism. When they put in ethics as well, and there are 7 different things here. And so the question is this a necessary evil, that something we just have to teach the residents and teach them through these SCORE curriculums, or how do we bring this to life? Well, the real answer is leading by example. Okay, it's important, yes, to understand the different scenarios, and I think I'm not trying to belittle the SCORE curriculum, but if it's not backed up by the leadership, the division leaders, the department of surgery leaders, or the people who are respected in your department, it's not going to happen. So for everybody who works in an academic situation, everybody who has a junior partner, this is one of the most critical aspects of professionalism. Setting an example is not the main means of influencing others. It is the only means. So think about that when you behave, how you speak to people. Disruptive behavior. So now the term is professional conduct. We don't say, okay, this is disruptive behavior, because that by itself is pejorative and suggests that you've already made a judgment. Professional conduct is how we're supposed to refer to it, but disruptive behavior, I think, grasps this well. This slide is from a friend of mine, Oscar Guillemendigi, who's done a lot of work with Jerry Hickson. And I think it really just shows a lot of what this looks like. And we've probably seen this in some form or another, and seen what this looks like and the impact that it can have. So what are examples of disruptive behavior? Well, profane or disrespectful language, demeaning behavior, sexual comments or innuendo, outbursts or anger, throwing instruments or charts. Still happens. Maybe it happened more in the past, but it still does happen. Criticizing hospital staff in front of patients or other staff, negative comments about another physician's care, boundary violations, inappropriate chart notes, meaningless abuse, meaningful use, electronic health records. We'll talk a little bit more about that. But inappropriate chart notes is actually something we need to focus on in today's day and age, in unethical and dishonest behavior. This work done by Jerry Hickson in Vanderbilt also shows that it's 9% of the doctors who really account for 50% of the overall complaints. So here's a percent of complaints and the percentage efficient. 35 to 50% really get no complaints. And some people slip up every once in a while, but there are certain people over here. And you can't always identify them, but for those who run the quality and safety programs, you see them. They get many trips to the boss's office or another office. These are the people you need to identify, and these need the people who need some additional work. And there are a lot of ways that this can happen. Leadership, I said, is probably the most important aspect. If it's tolerated, and it happens. You know, the people who are the high volume providers, the people who are the cash cows for the department, if you let them get away with it, that's going to be a problem. You have to have supportive policies with regards to that. Surveillance tools, some kind of data reporting, some kind of neutral zone for people to present these complaints, and a process to look at this. Multi-level training and resources to help address unnecessary variation, and also resources to help those affected. So I think these are all critical components. Again, from Jerry Hickson, this slide is from, again, Oscar Guillemendigi, but I think it really highlights this kind of professional pyramid here. Again, most of the things, vast majority of professionals, there's really no issues. But when something happens, it could be something really, really, really bad. And then you have to report that. Then you have to escalate that. Then you have to bring it up to kind of a level 3 intervention if it's that egregious. But single unpreventable incidents, that's when you have a cup of coffee. That's when you sit down and you say, hey, do you want to have a cup of coffee? And, you know, I heard about what happened the other day in the operating room, and do you want to talk about it? And you address it from there. If this is repeated or an apparent pattern, then you have to bring it up to another level. And this escalation with the pattern persists is something that if you don't escalate when the problems escalate, then you're going to tolerate it, and then that won't work out well for everybody. And it will then engender this throughout other people throughout your organization. So I want to give some pitfalls with regards to professional behavior. The concept of publish or perish. Through this, we all have these we all have disclosures with regards to industry and things like that. But few people disclose about their academic interests, the fact that they need to get this done and get their grant. There's a lot of production pressure around academics these days. Has anybody heard of Eric Pullman? I don't think he's presenting today. Eric Holman is a scientist in the field of human obesity and aging. And he was the first academic in the United States to be jailed for falsifying data in a grant application. Okay, this is a couple standard deviations away, but you know, these things have serious repercussions. And not only these major incidents where there's repeated events, there's years of denial, and eventually there's a admission of guilt, but the smaller things. You know, nowadays, when manuscripts are reviewed, a lot of times they look at electronically for plagiarism, plagiarizing your own previous work or plagiarizing other people's work. It's a different day today, and we have to be very careful with regards to this concept and the pressures put upon people. The dollars are less with regards to grant funding, and the levels for promotion are higher, so we have to be very sensitive of this. Here's another pitfall: disparaging an asleep patient. Interesting that I spelled it wrong. No, but interesting. This was a patient who was getting his colonoscopy instructions, and he turned on his cell phone so he would remember the colonoscopy instructions, but he left his cell phone on when he got his colonoscopy done. He was very surprised when he tried to listen to those instructions again, and this led to a $500,000 lawsuit with the staff being dismissed. But nowadays, you know, the camera's always on, the recorder's always on, or there's someone always out there. So anything we think in the moment, which we think may be funny, is not funny. And we always have to think about that patient's asleep and how they might feel with regards to that. Here's a bad one: carving your initials on a patient's. Not very professional. Here we have a person who actually put his initials AZ on that C-section scar with regards to that patient. A surgeon who would put his alma mater initials on the uterus before he would take that out. And then hand the patient the video with regards to that. Pretty egregious, pretty far out there. And again, this is not what we're most concerned about, but it's those little things in the OR. The little things, if it's perceived, or if you are treating a person who's asleep with not the respect that they should when they're vulnerable and asleep on the table. If you ever see this happen, and I had as a resident, it really took me by surprise. And it's not something we should tolerate going forward. This guy trained at our hospital, actually, and he left his patient on the operating table so he could cash his paycheck. Egregious, you know, problem with professionalism. But again, if you look at the boundaries, you can also look at the kind of the gray zones here, the areas where, you know, where we could do better with regards to that. Yes, we shouldn't go to the bank in the middle of an operation, but, you know, simultaneous surgery, double booking surgery, things like that. It's in the news a lot these days. Where do you draw the line with regards to that? Where do you draw the line with regards to what you say to your patient with regards to your involvement, what the resident or fellow actually does? And I think you have to be completely above board with regards to all these different aspects. And billing. So billing right now is a critical aspect as well. In different hospitals and different people, it's been their culture. Well, everybody's doing it. You know, if the neurosurgery resident does a case, we bill for that. Well, you have to be there. And if you attest to it, then you need to be there. And if you're going to bill for it, you need to attest for it. And those things are not really gray zones anymore. But it happens all too frequently. And now some of these other areas: compromising patient care or commitment for patients, or commitment to patients due to outside factors. We all have these forces. Aurora articulated them very well. And where do they start, impending upon your personal life? If you want to get out to see your family, that's not my family, but if you want to get out to see your family before the sun goes down, then maybe you don't see that post-operative patient, or maybe you don't spend as much time with them. And where do you draw that line from a professional standpoint? Challenges from today's healthcare with regards to documentation that I talked about, medical records, templates, attestations. I was present and scrubbed the entire procedure. I reviewed the entire note, and I agree with the complete plan. All that garbage that goes into EHRs right now, we have to be very sensitive about. And the production pressure, whether it's RVUs or efficiency in the OR or just life, really can weigh pretty heavily. And the other ones, financial accounting, billing fraud, undisclosed dollars from industry, and relationship temptations are and will always be an issue with regards to humans, as far as I can tell, having looked at this from a quality and safety standpoint for years now. So I was asked to talk about ethics and professionalism, keys to success or necessary evils. Well, I think ethics and professionalism is necessary for success. It's not the keys, it's necessary for success. And unethical or unprofessional behavior are really keys to disaster. Thank you very much.